You ever have one of those nights where you're just hoping for maybe an ankle sprain? Some guy who's thinking he's having a heart attack, but it's the Taco Bell he had? Yeah, this wasn't one of those nights. This was a night where a grown man decided to remove his jaw with a fence post. And lucky for me, I got front row seats. No eye protection. It's the middle of the night. A small town, small ER. Right in that sweet spot. Drunks are still out and about, but they're starting to trickle in. It's quite enough, which is a word that you'll never hear uttered in the ER. But so quiet you can hear the vending machines humming, nurses clicking away at their computers at the nurses' station. And for me, I'm the break room. This is my first opportunity to actually sit down and eat something. But everybody knows, as soon as you do, or even start, something's going to happen. Not 30 seconds after I started heating up my food, the crackles of the radio goes off.
This is paramedic on Rescue 13, patching for a trauma red. I have a middle-aged man with major facial trauma after his face collided with a wooden fence post. Patient is able to maintain airway. IV has been established. 50 mics of fentanyl has been given for Zofran. We'll give 50 mics of fentanyl again prior to arrival. ETOH is on board. ETA 5 minutes.
Yep, that sounds about right. Now, typically you listen to the end of that patch, but you got 5 minutes. You got to start getting the room prepped. You got to get the ranger ready in case there's a mass blood transfusion or for any other things you need. Medications for intubations. So there's no time. And with these smaller ERs, there's no trauma surgeon, no trauma team, no trauma room. Just your regular resources. If it's real, it's really going to test your ER knowledge. And your 5 minutes is up. EMS is barreling through that door. Now, typically what you do with a trauma is your across the room assessment. Your immediate what is going on, what's going to kill him, what are you seeing? Yeah, my across the room assessment. This isn't your typical car accident, and this is definitely real. Now, these first few minutes are crucial, but they're extremely chaotic. Everyone is talking. Everyone is doing something. EMS is trying to give handoff or a report, essentially telling us what happened, if anything changed from the patch, anything that they're seeing. Their report goes.
Patient was passenger in the vehicle, sticking his head out the window. Driver got too close to the edge of the road, and the passenger hit a wooden fence post, and it looks like it took off his lower jaw.
The EMS is right. Not broken, not fractured. It wasn't there. But not in like the gone in a clean way. It was definitely messy. Tongue was intact, and unfortunately the patient was trying to talk. Now his airway was maintaining. Essentially, he was able to breathe on his own. But without his lower jaw, he wasn't able to clear his airway as well as the rest of us. Now, to give you an idea, just try to say some words without the bottom of your jaw. Open your mouth real wide and just speak. That's essentially what this man was doing. It was so difficult for him to say anything. And that's a red flag. Now, just because he's maintaining his airway right now doesn't mean he can sustain it. And sure enough, as soon as he leans back just a little bit, you can definitely tell he starts to struggle more. And that's where my job comes in. Hold pressure on what's left of his jaw without blocking his airway. Holding enough pressure to try to stop that blood from pooling, but also not too much pressure to essentially suffocate this man, cover up his airway, or allow blood to leak back into his throat. I get 4x4s 4-inch by 4-inch gauze, and I get a lot of it. And I hold pressure, trying to protect his airway and allow as little blood as I can to go down his throat. And as I do this, I start to feel hard pieces of something. Now, I assume that it's bone, but I would be mistaken. Now, this is the part that may seem callous, but in this situation, he continues to try to clear his airway even though we're trying to hold pressure. And I don't blame this man at all, but he continues to try to blow those raspberries. Now, think about when you blow a raspberry and all that saliva that leaks out. Well, this is blood, and a lot of it. And so for me, luckily enough, I didn't have my safety glasses. And so the only thing I could do, close my eyes and turn my head, avoid that occupational exposure. Now while I had my eyes closed, I was doing my best to hold pressure, left hand on what is left of his mouth, and my other was essentially bracing on the stretcher. And the one thing that I wish I was making up for dramatization of this story was this man grabbed my hand and squeezed. Now with that squeeze, I could just immediately tell that this man, although inebriated, could tell the gravity of the situation. That squeeze just relayed how much terror this guy was in. Trying to scream out, I don't want to die. I'm scared. Multiple times. And that, oddly enough, I could understand. It was clear as day. Well, I did my best to stay out of my head. Luckily for me, someone behind was able to put their safety glasses on my head. Now while I'm struggling, the doc, he's weighing his options. No lower jaw means no easy way to secure an airway. And we all know we have to secure an airway. And remember, these aren't trauma surgeons. These are ER docs. And there's not very many options. He can do a traditional endotracheal tube, which is essentially just a tube that goes down his throat and helps him breathe with a ventilator. The other is a criciotomy. A criciotomy is where they essentially cut open your throat and stick a tube down that way. And either way you do it, you gotta lay them flat. And we already discussed what happens when he lays flat. Now, as soon as you lay him flat, he'll have seconds to try to intubate this patient. And although he does this probably pretty prevalently, he's going to have to do it with blood continuously flowing into the airway, trying to maintain suction so that he can visualize the cords or the vocal cords. So we have to sedate, paralyze, lay the man flat, and have the doc intubate the patient within 15 to 30 seconds. So attempt number 1, we give him 2 medications. One, a sedation medication, and the other, a paralytic. The paralytic essentially makes it so he can't breathe. Medications were given. Patient's laid back. Doc actually does a good job. Takes a little bit longer than normal, trying to suction all that extra blood to see what he was doing or where he's placing the tube. And as soon as they inflate the cuff, which essentially keeps it in place, it doesn't work. They keep trying and nothing. So, essentially what they do is they pull it out, they sit him up, and they try to bag him. Now, when you bag someone, essentially you use a bag valve mask. And what you end up doing is you try to get a good suction around a normal mouth. But with this man, you can't do that. And on top of that, every time you squeeze the bag to force air into individuals' lungs, it's also forcing the blood and anything else into this man's lungs. Now, the confusing part is, why is the cuff not inflating? So they try attempt number 2. Maybe attempt number 1, it was just a bad endotracheal tube. Maybe the cuff was just bad. So they try it. More meds. The doc inserts the tube. And again, successfully he got it. But when they inflate it, it does not inflate. And the problem with that is, if it doesn't inflate, it doesn't hold a seal, it doesn't protect the lungs, and it doesn't hold it in place. Every time they pull the tube out and they look at the cuff, and the cuff is just a small balloon, kind of looks like a plastic bag, it's torn. Both times. Now, first one, maybe some kind of defect. Second one, yeah, not so likely. Something is in this man's airway that's essentially cutting the cuff on the way down or while it's in there. So what do we do? Well, attempt number 3. And again, for anybody out there screaming tracheotomy, not a level 1 trauma center, not even a level 2 trauma center, no trauma surgeon. I don't fault this doc for not doing one. But the third time was the charm. Although the tensions could be felt in the room, it was palpable. He was able to secure the airway, at least we thought, and get him over to CT. Now the CT scan will at least help us visualize what's left of his jaw. If there's any foreign debris in his airway, essentially what's cutting the cuff, seeing if there's just something in there. Also, check out his head, brain, chest, everything else, just to make sure we're not missing anything, like an anoxic brain injury from the lack of oxygen that we were not able to get him while trying to intubate him, because using a bag valve mask was just not going to cut it. Now, I did say that this hospital was a small one, and it wouldn't be able to actually take care of this patient. We're here only to provide life-saving measures, nothing else. So essentially, we have to call an air evac team to take him to a bigger hospital. And luckily for us,
This is Flight 2301. We're ETA 5 to 10 minutes. Let your security know we'll meet them on the pad.
that's just enough time to get the CT finished, get him back to the room, and assess the ET tube. And on that assessment, you guessed it, 3 for 3. Cuff was blown. Something was tearing those balloons, and nobody knew what it was. CT, everything was so messed up it was hard to see anything. The only thing that you could see on the CT scan was pieces of wood, not bone, that was left in his jaw, or the flesh that is where his jaw used to be. So, out of options, out of time. Flight team arrived. The doc and the flight nurse and flight medic placed a smaller E2 tube, hoped for the best, and packaged him and sent him. And that was it. No update. I don't know anything about him, his name anymore, anything. Just that memory. And when the dust settled, well, my scrubs, arms, pretty much everywhere, my badge covered, and just small dots of blood everywhere. Took a long shower after that one. So the moral of the story is keep your hands, feet, and all extremities inside the car at all times.